Last time we wrapped up talking about what happens with HIT and other hypercoagulable states, and we had a pretty good revision of the step 1 topics related to coagulation and hemostasis. So now we're looking at other major high yield topics that you're going to definitely see. You've definitely seen already in step 1, and you're going to see more of it in CK. So here we have DIC, disseminated intravascular coagulation. In the real world, this is most commonly a major complication in women who are having pregnancy-related problems, right? Either they're trying to get an abortion or they have failed conception where the child may be just not a real fetus. Maybe it's like a molar pregnancy or something, right? Or had an abortion and something got left behind. So that's usually a major real-world scenario where we still, even today in 2021, see DIC. Here they mention some of the other things. So DIC is basically an acquired coagulopathy caused by deposition of fibrin. So this is key, right? This should be like bright red and complete bold and highlighted because this is the main issue causing factor. Fibrin is the one that's causing DIC. Deposition of a lot of fibrin, well, not causing it, but causing the symptoms of DIC. Deposition of a lot of fibrin in all your small blood vessels, leading to thrombosis and end organ damage. It can kill you. Depletion of clotting factors and platelets leads to a bleeding diathesis. It is associated with many severe illnesses and is often seen in hospitalized patients. So here's the main clinical things. So common associations, first one, boom, right there, obstetric complications, right? Amniotic fluid embolism, abruptio placentae, which is a complication related to pregnancy, and there's a bunch of other complications as well. This is only two. All your obstetric complications, all of them, can lead to DIC. Sepsis is another case scenario that can lead to DIC, although it's rarely the topic in a question. Malignancy can definitely lead to DIC, especially your blood cancers like AML, or a pancreatic cancer, which has many things going into your GIT, which then can go anywhere else in your body, right? GIT stuff, as we've seen, can use the portal system to go to your liver and go to many different places throughout your portal system, as well as connect back from the portal system into hepatic veins and connect to the IVC and go to the rest of your body. Burns, again, not a really common scenario for things that lead to DIC, but okay, so burns and sepsis definitely, I don't think I've ever really seen a question where either sepsis or burns led to DIC. But when you see a question about an obstetric complication, that should immediately ring a bell in your head, and you should start thinking, oh, maybe this question is about DIC. APL is just like AML, another blood cancer. Pancreatitis, basically relevant to pancreatic cancer. Never really seen hemolysis, not really. I haven't seen aortic aneurysm or any vascular disorder leading to DIC, massive trauma, snake bites, drug reactions, acidosis. Some of these, transplant reactions, yes, this can definitely a major thing that can also lead to DIC, and ARDS, acute respiratory distress syndrome, also another major one. ARDS is a story that can be due to sepsis, right? Many things cause ARDS. Sepsis and pancreatic issues are also two major things, as well as even amniotic fluid embolisms. Many of these other scenarios we're seeing in the earlier part of this big paragraph can lead to ARDS, which can then in turn have ARDS lead to DIC. Right? So these are things you have to watch out for in a question. And the main thing you'd be watching out for are the things we care about when it comes to CK, right? Diagnosis and treatment. Clinical presentation is mainly going to be bleeding from venipuncture so you've probably seen this in questions already. Right, many times they'll show that there's blood coming out from wherever they've got the patient needles at. Bleeding into organs with ecchymoses and petechiae. Petechiae is usually a sign in patients that they're running out of platelets. Right? So this is something you usually see in thrombocytopenia. So that is what's happening here, right? The reason people are put at risk of dying basically in DIC is because you run out of everything. You use it all up. That's what they're saying here. Depletion of clotting factors and platelets. You run out of everything because you used it too much, because you had disseminated, which means all over your body, intravascular, which is in between or inside blood vessels, inside blood vessels, and coagulation. Right? So it's happening, it's in the name. It's happening everywhere, so you run out of these coagulation factors. Chronically, you might see bruising and mucosal bleeding, thrombophlebitis, which is usually also an indication that the patient might have some malignancy. renal dysfunction, respiratory dysfunction, hepatic dysfunction, everything stops working. Right? Everything stops working. So what do you look for? Well, both PT and PTT are going to be high because you ran out of all clotting factors, intrinsic and extrinsic. You're going to run out of platelets, right? So you get the thrombocytopenia, which causes the fatigue. And one of the key things you look for during a diagnosis is your D dimers. Elevated D dimer and, of course, the key guy, the big key guy from up here, elevation in fibrin. That's the thing that's causing the symptoms of DIC, right? Deposition of fibrin in all your blood vessels. And you run out of fibrinogen. So remember, these names were also relevant to something else. Let me actually, instead of swiping up and down, let me open up what we have here as well. Right here. Right, so remember that these names were actually names of your clotting factors, these guys, right? Fibrinogen was clotting factor 1. When it became activated, thanks to 2A thrombin, you get fibrin. And this fibrin is basically causing these fibrin meshes in all of your blood vessels. Right, so that's what DIC is. So you run out of fibrinogen because you converted all of it into fibrin, and you get some D dimers as well. So you can see what the D dimer is right here. It's a degradation product. Fibrin degradation product is D dimer. When you make a bunch of fibrin that you didn't really need, like in DIC, you're going to break some of it. That's going to give you D dimers. DIC may be confused with liver disease because in liver disease you also run out of all your clotting factors. They're made in the liver. But unlike liver disease, factor 8 is also going to be low. Remember that in liver disease, factor 8 may not be low because factor 8 is safe within your von Willebrand factor, within your endothelium, within the blood vessels. But in DIC, you even run out of factor 8. So this is going to be something you can get a question on, right? How would you differentiate liver disease from DIC? Check factor 8. Right? Of course, the other answer choice is to check for D dimers and fibrinogen. Right? Elevated D dimer is also another differential, but if that's not an answer choice, because D dimer is too easy of an answer choice. Everyone that thinks of DIC thinks of D dimer. It's really easy to think of that, right? The D part. But the factor 8 thing is a more pathophysiologic thing that you can get a question on. And how do you treat it? Just reverse whatever's causing the DIC. Fix it. So for example, if there's an obstetric complication, maybe you had abruptio placentae and some placental part got left in the mom, you need to get rid of it. Take it out. Right? Do whatever it is that you need to do to fix the associated issue that was at the root of causing DIC. Once you fix that, then you have to transfuse red blood cells, platelets, and fresh frozen plasma to replenish everything that's been lost, right? So it's very clear from the disease itself, the pathophysiology of the disease tells you how to treat the disease, right? The main issue was that you acquired something that caused coagulation problems. So you get rid of whatever that problem was, and then you replenish the entire depletion of clotting factors and platelets. Right? That's basically it. That's all you really have to do. Right? So now we can take a look at this question here to kind of see what DIC presentation and issues look like. And then there's a table at the bottom we'll go into to further differentiate acute versus chronic, like it's written here. So we have a 56-year-old man comes to the emergency department with right leg swelling. He noticed the swelling yesterday and has not had injury to that leg or a recent fall. So no obvious reason for the swelling. He has no chronic medical conditions, takes no medications. On review of systems, he endorses frequent nosebleeds and occasional gum bleeding, which began recently. He has also had persistent, nagging epigastric back pain. So actually, let me grab my pencil to tell you things I would be highlighting in this question. The first thing I would highlight right here is already the main issue. He's presenting with right leg swelling. And then the next thing I would highlight is the fact that he has these frequent nosebleeds. Right? This is pretty weird. It's not very common for anyone to have frequent nosebleeds. And it began recently. He has also had persistent nagging epigastric and back pain. So another thing I would highlight, because epigastric pain that can radiate to the back might be related to pancreatitis. That's something that can occur. He has lost 10 pounds over the past 3 months despite no change in diet or activities, which is almost a red flag symptom of possibly having some kind of cancer. He has smoked a pack of cigarettes daily for 30 years, which further endorses our suspicion that he might have some kind of cancer. He doesn't drink, temperature's fine, blood pressure's fine, so he's hemodynamically stable. So I don't need to highlight it. Remember, you should always highlight the temperature and stuff, the vitals of a patient, if it's not hemodynamically stable. If it is stable, there's nothing to highlight because there's nothing wrong in here, right? But hemodynamic stability is a huge deal in CK because that's what you use to figure out what test to order or what procedure to follow, right? You can't order there are many tests and procedures that you can't do on a patient if they're not hemodynamically stable. All right, so that's when you highlight it, when they're not hemodynamically stable. This guy is fine, so I'm not going to highlight any of that. Chest exam is fine, so again, I don't need to highlight that. Mild epigastric tenderness is present. We already got that. There is moderate asymmetric right lower extremity edema, which was his main thing, right leg swelling. Peripheral pulses are full and symmetric, so that's great. Further evaluation is most likely to reveal what else. Now, 40% of people chose the correct answer, which is a pretty low percentage, because then 45% of people actually chose between two other answer choices. It's not like the other 60% were just completely lost. No, they had a suspicion that was different from what I have. In this patient with asymmetric leg swelling suggestive of DVT, several features are concerning for chronic DIC in the setting of cancer. The suspicion that I developed when I read the fact that he has epigastric and back pain. See, people will either have one or the other, right? You might have epigastric pain, aka heartburn, because of GERD or something, or epigastric pain alone because something's not going well in the stomach. Or you'll just have back pain, in which case it could be an older person who might have prostatic cancer that's, metastasizing. But to have both together usually means that one is radiating to the other. And the fact that this sentence was followed by weight loss and pretty extensive smoking history further made my suspicion more reasonable that he might have a cancer. Right? So anyone that presents with a single leg swelling that isn't due to heart failure, right? Because remember, in heart failure you can also have pedal edema, leg swelling, but it won't be single. Usually both legs are going to swell up. So single leg swelling, you usually want to think of that as DVT. Right? They don't mention if it's painful or not, so you can assume it probably isn't, but it sounds like DVT, and his weight loss and stuff was pretty significant, and that's the suspicion you should have had. Right? But other people thought of something else. So because of this suspicion of cancer, I would pick consumptive coagulopathy. A consumptive coagulopathy is basically exactly how you would describe DIC. DIC is a consumptive coagulopathy. We know it's a coagulopathy. That's what it is. And it consumes all of your clotting factors and platelets. That's why you call it a consumptive coagulopathy. 20% of people chose cryoglobulinemia, which is usually related to Hep C. You have to remember all the things for Hep C. So let's do a quick revision of that just to show you how you're supposed to remember all the things of Hep C. Let me see. So when you look at Hep C right here, right? Hepatitis C and B are both pretty high yield. For Hep C, there's a bunch of C things, and one of them is this. Right? Chronic HCV can lead to cryoglobulinemia, which induces a small vessel vasculitis that kind of looks like someone has petechiae, but it's not petechiae. This is actual vasculitis. Look at how bad that is. The 3 arrows, right? So this is a C thing, which is for Hep C. Right? That's not what our current patient has right now. His liver is actually fine. Remember, this is going to be a major comparison you're going to have to make when you're looking at questions regarding coagulation. Is it liver failure or is it DIC? And this guy's problem is not a liver problem. So it wasn't cryoglobulinemia. And then the other 25% of people chose thromboangiitis obliterans, which is actually something that's more so related to extremely bad smoking history, where people also often have Raynaud. And this was something that's discussed in step 1, cardiovascular pathology. His long history of smoking combined with unintentional weight loss and nagging epigastric and back pain raises suspicion for pancreatic cancer, because that actually causes epigastric pain because of the burning of the enzymes and whatnot that's leaking out, and the pancreatitis that might be occurring that radiates to the back. Mucin-producing tumors often secrete tissue factor into the blood. Remember, tissue factor was your guy right here, this one, right, which activates the extrinsic pathway. So most of your mucin-producing tumors will secrete tissue factor into the blood, intermittently triggering coagulation cascade, leading to chronic DIC, which is a consumptive coagulopathy. In contrast, acute DIC usually arises in the setting of a sustained procoagulant exposure and is marked by massive activation of the coagulation cascade, with rapid consumption of platelets, coagulation factors, and fibrinogen, leading to acute bleeding rather than thrombosis. But this guy has thrombosis. That's what his DVT is, deep vein thrombosis. Right? And you can tell he's lost all of his platelets. That's why he's having frequent nosebleeds and occasional gum bleeding. He probably also has thrombocytopenia if we look at the rest of his body more. So that's basically all that was, right? Now, the other transit trace is cryoglobulinemia. This is a medium vasculitis caused by precipitation of circulating antibodies. Is most common in the setting of infection of Hep C, monoclonal gammopathy, or connective tissue disease, none of which this guy has. Right? And in cryoglobulinemia, you don't get thrombosis and that kind of bleeding. Right? Thromboangiitis obliterans, medium vasculitis once again, that occurs in young patients who smoke and generally causes distal extremity ischemia, digit ulcers, ulceration of the fingers, and digit gangrene, which often initially first starts with Raynaud phenomenon. Right? Every time they smoke, the vasoconstriction of the fingers will make their fingers all blue and stuff. Right? So that's kind of how you differentiate between acute versus chronic DIC. If we look at the differences here, of course, chronic DIC usually is just due to cancer, because cancer is a pretty chronic thing. Right? It's something that some patients often have that they don't even know. The most notorious cancer you can have that you might not know you have is the pancreatic cancer. Right? And by the time you do know you have pancreatic cancer, it's usually too late. Now, if you look at the differences in this table, right, one of the biggest differences are the last two things. Right? Bleeding risk is very high in acute DIC. But chronic DIC has a little bit of bleeding, not excessive. And then the opposite case scenario, in acute DIC, thromboembolism won't occur. Right? It's only mildly increased, and for the most part, it won't occur because STEP is going to try to help you figure out the difference. But in chronic DIC, you're definitely going to get it, a thromboembolism. Right? And in chronic DIC, look at these guys. Your coagulation studies, your platelets, your fibrinogen, usually going to be pretty normal because it's not an acute case scenario where you just had a sudden attack of DIC and everything got used up. This is a chronic issue, a developing cancer that's worsening with time, which is slowly going to eat away your coagulation factors, your platelets, and your fibrinogen, but you're also replenishing it at the same rate as being eaten away, so it's often normal. Okay. Here in acute DIC, you get rid of it too quickly to replenish it naturally from your own body. Next case scenario, TTP, thrombotic thrombocytopenic purpura. This and the other one after this, ITP, are very high yield. Right? Those are the two big guys that are very, very high yield. So let's actually go back and look at it in step 1 because it's actually discussed a little better here. Let me see. TTP and ITP. Right here. Okay, so your platelet disorders. Those are both thrombocytopenias, which are platelet disorders. Right, remember that in platelet disorders, you have prolonged bleeding. Right, you bleed for too long. All platelet disorders have increased bleeding time, mucous membrane bleeding and bleeding in the gums, microhemorrhages like petechiae all over the body, nose bleeding, right? Platelet count is usually low, but may be normal depending on whether or not it's a qualitative disorder, where you're making platelets, but they're just not good. Functionally, they're messed up. So the first two we already talked about, Bernard-Soulier and Glasman thrombocythemia. These were the case scenarios where you're missing the GP guys that are supposed to do your primary hemostasis. GP1B had one job. It was to connect your platelet to the endothelium. Right? So platelet to von Willebrand factor adhesion is messed up. And then Glasman thrombocythemia has the job of connecting two platelets. These numbers help you remember the GP that it's related to. GP2B connects two platelets. GP1B connects one platelet to the source where the cut is. That when you get a cut, you release von Willebrand factor from that endothelium cut, and it connects to platelets. Right? In both of them, you can do the ristocetin test to see what happens. In Bernard-Soulier, remember ristocetin is supposed to activate von Willebrand factor to connect to GP1B. In Bernard-Soulier, you don't have GP1B, so giving ristocetin does nothing. In Glasman, though, you do have GP1B and you have von Willebrand factor, so everything will be okay in response to ristocetin. All right, but there's a defect in aggregation. Without GP2B, you can't get multiple platelets to connect together, so you get a very weak platelet plug formation. Although Glasman thrombocythemia is a problem, it's usually not a major problem because at least you can get platelets to stick to the site of cutting, right? And then eventually secondary hemostasis will kick in and coagulation factors will reach and everything will close up. Now we're looking at our ITP and TTP. That's where we're up to. So the first one they talk about is TTP. So let's look at it. Thrombotic thrombocytopenic purpura, which also has HUS as a topic here. Disorders overlap significantly in symptomatology, but they have major differences usually related to the source and the age of the patient. TTP is an inhibition or deficiency of ADAM TS13, which is actually a von Willebrand factor metalloprotease. Usually questions will have this as an answer choice, that there's something wrong with some metalloprotease, which is ADAM TS13. When you have a problem with ADAM TS13, you get decreased degradation of all of your von Willebrand factor multimers. So you end up seeing large von Willebrand factor multimers, which actually ends up causing more platelet adhesion and aggregation. And if all those platelets are adhering and aggregating in places you didn't need it to happen, you get microthrombi formation. That's all that you see in these people. So of course they get petechiae. And they're going to run out of platelets because all those platelets are aggregating even though you don't need it to. In HUS, this is commonly caused by a Shiga-like toxin. So you can see clearly a completely different source of how this is occurring. A Shiga-like toxin from enterohemorrhagic E. coli, serotype 0157H7. Atypical form, the AHUS, the atypical form is caused by complement gene mutations or some autoimmune response. Either way, there is a difference in the symptomology. We're going to see that right now. Presentation, triad. You're always going to see the triad, and I've broken down the difference with this mnemonic thing I made up here. So you're always going to see the triad of thrombocytopenia, microangiopathic hemolytic anemia, and acute kidney injury. How does this happen? Well, you got thrombocytopenia because all your platelets were coming together, so you ran out of platelets. You're going to get microangiopathic hemolytic anemia, which means that because in your blood vessels, it means that you're cutting up your red blood cells. Because in your blood vessels, you're going to create these pretty sharp-looking micro thrombi, right? You're going to create these microthrombi, and when your little red blood cells are floating through, they're going to get cut up. They're going to get stuck on this microthrombi here and get stuck on that one, and they're going to get all shredded up. Right? So you can already imagine you're going to see this because in these patients, when these red blood cells are going to break, they're going to release hemoglobin. Hemoglobin is going to connect with haptoglobin. So all these patients with TTP are going to have a low haptoglobin. They're going to run out of haptoglobin because all the haptoglobin is connecting with hemoglobin that's freely floating around. They're also going to present to you other things because remember, these questions are supposed to try to confuse you with liver disease, right? So they're going to show you there's a high bilirubin, which of course is going to happen because as we saw, anytime you have free heme just floating around, you create bilirubin. So it's not that the person has a liver disease, they're making too much bilirubin. So both things are going to be high. They're going to have a high direct bilirubin, which they made because they have too much heme. And they'll have high indirect bilirubin because the high direct got converted correctly by the functioning enzyme into high indirect. Everything's going to be high, both of them. But it's not because they have a liver disease or anything like that. It's because they have a bleeding disorder. Right? They're cutting up all their red blood cells. The microthrombi are like these big sharp things that weren't supposed to be in this nice clean blood vessel. And then the last symptom here was your acute kidney injury because of course all of this can also occur in the same blood vessel. This could actually be, it could occur in the same blood vessel that goes to the kidney. This could actually be your renal artery. So you get kidney injury as well, right? Now TTP has a pentad. It has this triad, but it also has fever and neurologic symptoms. HUS only has these three things. The triad, that's it. HUS will not have fever, and HUS will not have the neurologic symptoms. The more important thing, though, is that the neurologic symptoms won't be there. So that's what you look for in questions, because in HUS, it is possible to have fever, but it won't be due to the HUS. The fever will be due to the infection they have from whatever EHEC they got. Usually, it's a kid who had a burger at a new place, and the burger had EHEC in it. So that will lead to bloody diarrhea, because that's what enterohemorrhagic E. coli does. The hemorrhagic means you bleed, right? Enterohemorrhagic E. coli. Entero, meaning inside your stomach, in your intestinal system. Inside your intestinal system, you have hemorrhage, right? So that's what the bloody diarrhea is. So they could have fever, but not due to HUS. That's why they didn't write it here. right? You get fever because of the infection you have, but they won't have any neurologic symptoms. So I made this mnemonic: HUS is equal to ART, which is the triad: anemia, renal, and thrombocytopenia. TTP, I wrote fun art, right? So fever, neurologic, anemia, renal, and thrombocytopenia. When I made this up, I can't remember what exactly I was thinking of. I was trying to get a way to get these, the first letters of each thing, the triad, into words, and these were the only words I could think of. Right? So HUS is art, TTP is fun art. That's just something you have to think of, and if it sticks to you, then great. If you could use it, then definitely do, because it'll really come in handy when you look at questions. You'll be actually able to break it up. For example, look at this first one right here, 7-year-old boy. So already we know this is probably going to be more likely HUS than TTP. 7-year-old boy comes to the office for follow-up. A week ago, he began having episodes of bloody diarrhea because of EHEC, obviously, and these have since resolved, as EHEC and most diarrheas usually do resolve by themselves. Currently, lab studies show acute renal failure, so we got the R. CBC shows anemia and thrombocytopenia, so we got the entire ART. Anemia, renal, and thrombocytopenia. That's ART. Coagulation studies are fine because this is not a coagulation disorder. His peripheral blood smear shows a lot of schistocytes. Key things step 1 loves. CK won't really question you on it too much, but schistocytes in CK is indicative of the fact that this is something you need to use in real clinical practice. Schistocytes indicate that this happened. This scenario happened where one of the red blood cells that got torn up is now going to look like half a red blood cell that got ripped up. You get your schistocytes, your helmet cells, right? Because they got ripped up by the microthrombi. What is the most likely cause of his anemia? Microangiopathic hemolytic anemia, which is how you describe hemolytic uremic syndrome, HUS, right? Similarly, the other guy, TTP, this is the 32-year-old woman right here, reports fatigue, malaise over the last several days. Patient has not had any sick contacts. She doesn't appear to be in acute distress. After her initial evaluation, TTP is suspected. What is essential in making the diagnosis? So this question was really interesting. This was a very hard question, actually. Because in this question, they didn't make you think of whether or not it is TTP. They told it to you. They said, how would you know that this is the person you diagnosed as TTP? What key symptom was defined? And then look at all the symptoms. Abnormal neurologic exam, elevated BP, elevated liver enzymes, fever, hemolytic anemia, or renal failure. Which one of these things literally defines TTP? But those are all things you would find in TTP minus the elevated BP or the elevated liver enzymes, right? But fever, hemolytic anemia, renal failure, and neurologic exam are all actually going to be case scenarios of TTP. But the giveaway hallmark was apparently just hemolytic anemia, which is, of course, because how do you actually define TTP? It's this activity. You have microthrombi that are ripping up red blood cells. That is TTP. Not the neurologic symptoms, not the renal failure. Those are other consequences of this issue. But this is the actual issue. So you have to have this happening to pick TTP. That's what this question taught. Right? TTP is one of the primary thrombotic microangiopathy, and the hallmark are non-immune hemolytic anemia. Non-immune. It's not that antibodies in this person are killing his red blood cells or something like that. It's happening because he has these microthrombi that are ripping up. Great question from UWorld for step 1. Alright, so that's really all there is to that. If we come back here, we're going to get to see this question, right? 45-year-old previously healthy man is brought to the emergency department due to headaches and confusion for 2 days. He has no focal weakness or sensory symptoms. He has no significant PMH, past medical history, and does not take any meds. He doesn't smoke, drink, or do drugs. His temperature is a little high, so we can call that fever. Blood pressure is high. Pulse is almost tachycardic. It's up there. And respiratory rate is 16. So right now, when I'm reading this question, as I would highlight things, I would highlight the first thing, which is his presenting symptoms, headache and confusion. So that's the N. Right? That's a neurologic issue. No focal weakness or sensory symptoms, nothing else is wrong. And then I got to his vitals, and I see something that I'm concerned with, which is this. That's the F for a fever he has. It's not a high-grade fever, but it's a fever nonetheless. Mild icterus. So the icterus tells you that there's some kind of hemolysis happening in this patient, because it's not due to any kind of liver issue as far as I've seen so far. Maybe as we read the question, we might see more about how it is a liver issue, but I know it's not, so I'm telling it to you. But either way, we would highlight the mild icterus nonetheless. Right? There is icterus, so either he has some kind of bile liver issue or he has hemolysis. Right? His neck is supple without rigidity, cardiopulmonary and abdominal exam are fine. Neurologic exam, nothing focally wrong. So that means that he doesn't have any kind of stroke in the brain. Labs, so they show you CBC, he clearly has anemia. Right? His platelet count is low. Leukocytes 5500. Serum chem, BUN is high. Right? This is problematic. Creatinine is high. That's also a problem. That's the renal. So he has the renal, he has the anemia, he has the low platelet count. That's the T. Right? So now that's fun art. The U didn't stand for anything. So this is clearly TTP. Right? Which, to remember, to truly diagnose this to be TTP, what I most importantly needed was the hemolytic anemia. This case scenario, right? I really needed the hemolytic anemia because this was the one that's causing his icterus. Right? Because he's got all this bile floating around, that's going to increase his direct bilirubin, which is also going to then increase his indirect bilirubin. They go on to tell you that a peripheral blood smear is done and they see fragmented red blood cells, basically schistocytes, which is, again, this is extra information. They didn't need to give it to you, but UWorld is trying to teach you that all of these things will be seen together, so they showed you that. PT is normal, of course, because this is not a coagulation disorder, it's a platelet disorder. What is the best next step? Plasma exchange. That's it. TTP has the pentad of fun art, as I showed you. And the microangiopathic hemolytic anemia presents as schistocytes. Plasma exchange actually replenishes the key thing, which was the lack of ADAM TS13, a metalloprotease that's going to break those microthrombi that are forming. Right? It's going to break the von Willebrand factors, big von Willebrand factor clumps, so that you don't keep forming more microthrombi. And so that's the treatment. Plasma exchange, as they show you here as well. Right? Treatment, plasmapheresis. You could also use rituximab or steroids to stop things from happening, but plasmapheresis would be the easiest and quickest treatment for the patient. Right, so that's kind of all you really see. They're describing the same stuff again, where HUS is related to EHEC, and TTP is mainly related to a deficiency of the guide that breaks down your von Willebrand factor multimers. You don't want big von Willebrand factor multimers. And so that's all they continue to talk about. They also tell you here TTP is associated with lupus, malignancy, pregnancy, cyclosporin, quinidine, clopidogrel, a lot of things. Right? They didn't tell you that here. They didn't tell you other things it's related to, per se. So that's a little bit of new information for you. So a patient with lupus, if you get a patient who has lupus, high eotopic. If you get a patient with some kind of cancer or pregnancy, all of these are high eotopics. And then all of a sudden they're having these TTP symptoms of thrombocytopenia, hemolytic anemia being the key one, renal failure, and all these other fun art things. Then you truly start thinking it's TTP due to that whatever thing I've underlined. All right. The elevated blood urea nitrogen is critical too, because if your blood urea nitrogen is high, that's occurring because you released a lot of heme. Same reason, right? All that heme increases your blood urea, the amount of urea in your blood. And then the rest of these we already saw. HUS, again, same stuff, Shiga toxin or EHEC. Right? That's really all there is to that. And for them, their treatment, let me see, they tell you, just do dialysis. Right? Dialysis for the acute kidney injury they're getting, and plasma exchange once again, just for severe persistent disease. But it shouldn't be severe persistent disease though. Usually they get it right when they had that burger that caused, well, a little bit after they had that burger that caused the bloody diarrhea. Now they have HUS and then it resolves and they'll be okay. But worst case scenario, if things got really bad, they might need dialysis for their kidney injury. And if it keeps happening for some weird reason, then a plasma exchange may be necessary because it might actually be more than just HUS. Right? Platelet, this one you have to keep in mind. Do not pick this as an answer choice. Do not pick this. This is a trick answer choice. We know that TTP is a platelet disorder, and if you're tired enough to not realize that the disorder involves platelets clumping together to form microthrombi, then you might actually think this is a viable answer choice. Since this is a platelet disorder, why don't we give him platelets? That's not what you want to do. right? They're low on platelets. Why don't we just give them platelets? That is definitely not the mentality you want to have for this question, or you will pick this trick wrong answer choice, and it'll probably be answer choice A. Because as soon as you see it, you're going to be convinced it's correct, and then every other answer choice after that, B, C, D, E, F, are going to look wrong. All right, but you don't want to do this, because if you give them platelets, you're basically giving them ammunition to form more microthrombi. See, as additional platelets are consumed by the disease process, potentially worsening the condition. So don't pick this answer choice. That's a trick answer choice. All right. So it's great that we're talking about this to get this all down. You don't want to fall for any of that. Then comes the other one, the idiopathic shit that's happening for no reason whatsoever. You don't know why it's happening, or it's autoimmune, so immune thrombocytopenia. They talk about it here very simply. This is a destruction of platelets in the spleen. So right away, you already know that part of the treatment is going to be to do a splenectomy. But don't just jump to that answer choice. Keep in mind that the splenectomy is for refractory ITP. So this again is a trick answer choice you're going to have. And CK loves putting multiple answer choices that are viable answer choices, right? So you're going to look at a patient with ITP, you'll read the question, you'll know it's ITP, you feel great about it yourself now, and then you see answer choice A, splenectomy, and you'll just pick it. Don't do that. You don't need to get rid of the spleen if you can solve the problem with other things. Right? So this is a destruction of platelets in the spleen. Why? They have anti-GP2B3A antibodies. So they have antibodies against the receptor that was responsible for connecting two platelets together. So now splenic macrophages will phagocytose your platelets. That's kind of what ends up happening, because the antibodies are going to get attached to some of these platelets too. Maybe idiopathic or secondary to some other autoimmune condition, once again like lupus or HIV or HCV, some malignancy, or even drug reactions. There can be many things that can cause ITP. So usually ITP questions can start with anything, which makes ITP a very good topic, very testable topic. The questions about ITP can start with anything. Could be a patient coming in with cryoglobulinemia because he has ACV. You did whatever you had to do. You fixed it. 2 months later, they're coming back with, again, similar symptoms, but this time it's not cryoglobulinemia. It's this. It's ITP. So very important to keep these things in mind. You have to have the suspicion to even think of the answer choice. If you don't think of the suspicion, if you don't develop a suspicion, you won't think of picking this answer, right? In these people, what do you find on their labs? Megakaryocytes on bone marrow biopsy, and a decreased platelet count because their spleen is killing it. Right? So that's something you really need to keep in mind. How do you fix this? You give them steroids to stop the antibodies from being formed. You can give them IVIG, and you could use rituximab, or one of the most common answer choices on step 1 was to use this TPO receptor agonist, eltrombopag, ramiplostim. Right? These names remain perfectly. I mean, it has thrombo in it, so it tells you that this is definitely related to platelets, because platelets are thrombo stuff, and it's ending in AG because it's an agonist. It's an agonist to the TPO receptor. Same thing here, ramiplostim is a stimulator of making more platelets. Right, so these guys you could give platelets to as an answer choice. These guys, the problem isn't that their platelets are making something that's killing them. No, they need platelets, and you can give them platelets. Here you can. But don't fall to jump to this answer choice of splenectomy. Splenectomy is only for refractory ITP. So after you try one of these other answer choices to treat them with, if they come back again with ITP and again with ITP, then now you know you can't just keep giving them the medication. You got to get rid of that spleen. Right? So that's all they're talking about here as well. They have the breakdown of acute versus chronic, which is different. That's not here. Right? This is just one thing. So let's look at the difference between acute versus chronic, which should be pretty commonsensical because we know what acute and chronic means. So the acute one is an abrupt onset of hemorrhagic complications following some viral illness with sudden self-limiting purpura. So abrupt purpura after a viral illness commonly affects kids 2 to 6 years of age, with boys and girls affected equally. So any kid who's 2 to 6 who had a viral infection and then randomly got purpura that was self-limited. Chronic is an insidious onset of symptoms. So insidious means it's really, really scary and over time, not just all of a sudden in 1 minute. Insidious onset of symptoms or incidental thrombocytopenia on CBC. Remember that usually chronic things, since they're happening over time, they're happening so slowly that although you might be using up and killing your platelets, you're also making platelets at the same time, so it's replenishing pretty well. right? So you didn't notice that the patient had a problem until you did the CBC, and you just noticed their platelet count is a little below or far below than standard, right? It should be between 150 to 400K. There might be 100K. There is a fluctuating course of bleeding, purpura, and epistaxis, and menorrhagia. Affects adults 20 to 40 years of age, and women more than men, which is why most questions are going to be about women with menorrhagia. A woman coming in telling you that her menstrual periods are excessive. She's bleeding too much. Why is she bleeding too much? She has ITP. What are you going to do about it? Give her the platelets and then give her one of those treatments. So let's take a look at what are you going to do about it, because that's what we really care about, right? For CK, it's all about what are we going to do about it. So you can see the treatment aspect here is much more extensive than what we learned about in step 1. Right? That's the clear difference between step 1 and CK. In step 1, you cared about the pathophysiology of the disease, how does it occur, who does it occur to, that's it, not really how you're going to treat it. Now we're looking at how we're going to treat it. So diagnosis is a diagnosis of exclusion. Once other causes of thrombocytopenia have been ruled out, because it's easy to rule them out, diagnose it by history and physical exam, a CBC, and a peripheral blood smear showing normal red blood cell morphology. Antiplatelet antibody are often present. Bone marrow biopsy should show a lot of megakaryocytes, but is done only on atypical cases or patients over age 60. You don't pick this as an answer choice because it's not really something easy to do and you don't really do it that frequently. Plus, a bone marrow biopsy is very expensive. So, again, this is going to be an answer choice, but you don't really pick it because you don't need to do it. Right? ITP is simply a diagnosis of exclusion that you can sort of basically confirm if you find antiplatelet antibodies, the antibodies to GP2B3A, right, like that. Additional tests for all patients with ITP. You should do a Helicobacter pylori testing, hepatitis C testing, and direct antiglobulin test, as well as a blood type test. These are things you should order for these patients. Right? I forget why H. pylori testing. That I can't remember, but you do have to order it. Yeah, I can't remember why you're supposed to order a Helicobacter pylori testing, but I'll look that up after this session. Definitely something you should look up too. I can't remember why you order a H. pylori testing, but knowing why you order it will help. Hep C testing is obvious. First of all, most people, it's a common thing to have Hep C and not know you have it, especially if there's a person that came from another country, an immigrant. So that you should check, and Hep C has many vasculitides it causes, so it's relevant. H. pylori testing, I can't remember why you do that. Right? Now, treatment. Treatment is very testable here. Right? It's going to be on your question, on your CK. If there are only cutaneous symptoms, then simply observe. Very important to remember that. If the patient simply has cutaneous symptoms like acute thrombocytopenia, then just observe. If there is bleeding, then use glucocorticoids, IVIG, or anti-D antibodies. Alright, so let's take a look at this. Platelet count more than 30,000. That's still pretty low. But if their platelet count is more than 30,000 and there's no bleeding, then no treatment required. Very key thing to watch out for. Right? We are often very hesitant in picking the answer choice that says do nothing. But there are many case scenarios where we as physicians shouldn't do anything because 1, will save money, 2, will save some problems, and the patient is going to, not our money, we'll save the patient money because the patient will have to pay for the treatment, right? So we're saving the patient money from unnecessary treatment, and the patient won't have to go through any kind of stressors. The patient doesn't have bleeding and their hemodynamic is stable, we're good. Just observe. Wait till it gets worse, then treat it. If it doesn't get worse, you don't need to treat it. If the platelet count is under 30,000, which can happen, this case scenario 1 can lead to case scenario 2 in another few months. Or there is clinically significant bleeding symptoms. Use corticosteroids or IVIG. And now they go on to tell you some more things that are going to be relevant to the treatment. If the platelet count fails to improve after you do whatever treatment, or bleeding recurs, consider doing the splenectomy. So you see how you don't pick that as your initial answer choice. This is case number 3. Refractory ITP. It didn't fix even though you treated it. You could do a splenectomy, you could use rituximab, and you could use thrombopoietin, receptor agonists, TPO, right, which will increase platelet production. Right, so Romiplastim stimulates platelet production, and L-thrombopag is a thromboagonist. Right, these names are in the name of the medication. So you need to, these people, different from TTP, in these people you do need to give them platelets. In TTP you don't give platelets because platelets are the ones that are causing the formation of these knives, the microthrombi, that are killing your red blood cells and tearing them up. Platelet transfusions are not used except during splenectomy or life-threatening hemorrhage, as the platelets are quickly destroyed by autoantibodies. However, in acute scenarios, you might need to give them platelets. Depends on what the question is leading you. However, here, look at the wording. It just says they're not used because the body is just going to kill them again. But platelet transfusion is not contraindicated. It's not contraindicated. You can give them platelets, especially in case number 1. In these people, case number 1 patient, you could give them platelets. If caused by Hep C or HIV, then you treat the Hep C or HIV, and that can actually improve platelet count. And in pregnant patients, severe thrombocytopenia may occur in the fetus as well, making L-thrombopag and romiplastin even more significantly important in them. But you cannot give rituximab to a pregnant person. Keep that in mind. Rituximab is a very dangerous medication. In fact, someone who's taking rituximab is an IV infusion. I have a friend that gets this done. You can actually use rituximab for treating pemphigus vulgaris and bullous pemphigoid as well. I have a friend who has PV, pemphigus vulgaris, and my friend gets rituximab infusions every 3 months. And the infusion of rituximab is costing my friend $4,000 each time, every 4 to 6 months. That's how often my friend has to get rituximab. My friend has to keep doing this for a good 3 years, and I think right now my friend is up to the 2nd year, and it's all in hopes of the fact that the PV will not get worse. Okay, and my friend is a female, so that's why I've learned that you can't be taking that if you're trying to get pregnant or if you are pregnant. Right? It's not going to be good for that person. Even after the infusion, you have to wait. After the last infusion, you have to wait a good almost a year before you actually try getting pregnant. So it's a really problematic medication and hella expensive. Alright. The last thing here is this topic, which I wrote about right here, right? The anti-D. Anti-D or anti-RH immunoglobulin and rituximab are second-line therapies for ITP. Right? This is the same thing as ROGAM. These immunoglobulin and IVIG act as decoys so that the white blood cells will recognize these guys instead of the IgG on the platelets, and it will stop platelet destruction. That's all it really does. So it's not really a treatment as much as it is a way of tricking your body into not killing platelets and kill this instead. So you're giving a new target to the ITP, right? A new target for them to kill. And that's all this was about. Right? So TTP, HUS, and ITP. You should be able to talk about them very confidently and clearly distinguish them from each other without any issues whatsoever if you see any of them in a question. Alright, so that's it for that. I actually have to go to a meeting now, so I'm going to call it quits right here, and then in the next video we're going to wrap all of red blood cell disorders, which also means we're going to have to go back to step 1 again and look at all your iron panel stuff. So if you want to, before our next session, you need to get very confident at being able to talk about the things on this iron studies thing on this table right here. Right? Your MCV, whether or not it's micro or megaloblastic anemia. Your iron levels, your TIBC, total iron binding capacity. How much capacity do you have to actually bind iron? So as you can see in iron deficiency, your binding capacity is very high because you have a lot of seats open to bind iron. Whereas if you think of another disease, the opposite of iron deficiency, hemochromatosis, where there's too much iron, your total iron binding capacity is 0 because you don't have any space to bind iron anymore. There's too much iron to begin with. Ferritin is the true indicator of how much iron you have. Ferritin is the number count that tells you, do you even have iron? Clearly in iron deficiency anemia, it's low. And then transferrin is a ratio of iron to iron binding capacity. Right? In iron deficiency anemia, since your iron will be basically 0, the numerator is 0, so this is 0. Right? Whereas in other case scenarios, if your numerator is 100, then the number is going to be up, like hemochromatosis. Right? So we're going to talk about all of that for the other diseases. Here we only have 3 of the biggest, most commonly tested things, and the biggest differences are between these two guys, where both of them, it looks like iron is low, but there's a clear difference. Iron is actually low in IDA. Iron is very high in anemia or chronic disease, but you're just hiding all the iron within macrophages. So we're going to talk about all of that in the next session on Wednesday. I might actually get started with this on another session. Actually, I'm going to send you guys an email because I'm not sure if I'll be able to stream Wednesday. I might just stream tomorrow throughout the day to get multiple sessions in for anemia. But I'm going to email everyone about that right after this. Let me just check my schedule. All right, so thanks a lot for joining, guys. Enjoy your night tonight, and I'll see you guys again later.